restenosis, Zamboni has demonstrated that reoccurrence after the second dilatation is less frequent than following the first one. And I hear that you will comport with me. And secondly, if you can stop my progression, I have one every 6 months.
Can I just ask quickly, what's the thinking behind the second angioplasty?
It's also a huge topic, the secondary angioplasty, because as I told you yesterday and today, the restenosis rate is not very low. It's sure above 30%, between 30 and 40 maybe. So at least one third part of the patients, they are going to have a secondary procedure. But what we have discussed with Gianfranco, if the vein was diseased, all the vein was diseased in the primary procedure, in most of the cases the patients are coming with a very focal restenosis, and very interestingly, not so resistant as the first time. So evidently there are zones of more resistance and more fibrosis that they are more prone to restenose. And it's absolutely true. The secondary procedure is much easier and really with beneficial results compared to the first one. So it's not necessarily on the second procedure is necessary to implant a stent.
Okay, Pat, you have a question.
Thank you. It was mentioned earlier about the MS gene. Has that been proven that there is such a thing?
There's been a lot of work done. George Evers at Oxford University is probably the lead in the world in this. Once sat, obviously had nothing better to do, counted up £15 million of grants that his group had got. That was when I was looking for 50,000, so it was a bit deal. But he has done a lot of work. It's like most genetic work, it's not clear cut, there's not a single gene, but there's a group of genes. And the work they did in vitamin D, looking at the most common gene. So yes, you can pretty much say there's a genetic predisposition to MS, and if you don't have that genetic predisposition, then you will not develop MS. It opens up a very exciting area though, if something simple as vitamin D supplementation may reduce the expression of the gene, because although you've got the gene, it doesn't necessarily mean it's going to express itself.
Excuse me, but there are other issues that have not been addressed by the geneticists,
Yep.
and that is the genetic aspects of CCSVI. So there are a certain number of you who will have these truncular venous malformations. These are embryological problems that developed while you were a fetus, and so you're just not forming the veins properly in some cases. In many cases, we just see a stenosis. But in many other cases, you see this truncular venous malformation. It's literally a trunk, and it just doesn't connect with the rest of this. And there's a gap. Sometimes there's a thin string that connects it, and then you can have this venoplasty. Sometimes there isn't. So, and that trunk can appear at the top, it can appear at the bottom, and it can be in many different places. In fact, in certain families who have this, it is a genetic predisposition to have it. So what we need the geneticists to be looking at are those people who have this familial problem with truncular venous malformations. And maybe they should be looking more at vascular genes and the formation of the vessels themselves that would relate to this. So I don't think it's so straightforward that there's just one thing, and I think there's a lot to be learned there yet.
The word straightforward in genetics are never used in the same sentence, except to say it's not straightforward. But there is one paper that's been published looking at some of the genetic elements of CCSVI. But the only geneticist ever to have clear results was Gregory Mendel and I think Craig. Anyway.
So it's not possible when you have a test to see...
No. That was your supplementary question. You should have asked that first.
Thanks, I think, like most people, I'm a bit frustrated given the wealth of information that I've seen today, and the panel of experts up there, and it seems to suggest that there is, in fact, quite a significant link between MS and CCSVI. And I'm just really interested to see what you're going to do to work collaboratively together to keep this momentum going.
Yeah, I think that's an that as Donald alluded to, that's probably the most significant thing that came out of yesterday, was this desire to have this collaboration across the various centres that are doing this across the world. I think that's not going to be easy, it's going to be challenging, but without that, no one area is going to be able to carry this forward. So we have lots of plans to do that, and we've been discussing them for 40 hours. So there will definitely be an output. And the other thing that I'd like to think we can do is to repeat this conference in a year's time, and be able to report back on some of the progress that's happened. Because there'll be a lot happening, so right down to the very front.
With respect to Dr. Camp, you said you were happy to get the procedure done in 6 months if necessary. A lot of people couldn't afford to do that, and especially MS patients, a lot of them don't work. So, is it a one-off?
I mean, you're absolutely right.
I mean, you have to go back and be able to think.
I said that I would have it every 6 months. I didn't say I could afford to have it.
If anyone gets it done and it fails, do they have to do the full thing again to get it done again?
Sorry, I have no idea because I'm not involved in.
But I can answer that, and there are fixed costs that you really just cannot wish away. I mean, the cost of hiring a theatre, the cost of the 12 staff that were there on Thursday, the cost of anaesthetists, the cost of the consumables. These, I'm afraid, at the moment, this is why, and Michelle was discussing this is why really the effort that we put forward is to try and make sure that this becomes available through not just the NHS in this country, but through the tax-paid services throughout the world, because this is, as it stands at the moment, this does look as if for a lot of people it would be a recurrent, there would be a secondary procedure for a lot of people, and now hopefully that might diminish as techniques improve and as our knowledge improves, but we couldn't think this is one fix and it's going to be solved. So that is going to be a big issue, and I can tell you that it's impossible to take out some of these costs.
I know, I understand that, but would you be better to get the stents in then the first time?
I think a lot of people feel that if they get a stent, they're fixed forever.
Yes.
But Eva, do you want to comment on that? In fact, maybe there's more problem.
In fact, maybe I'm the most liberal to implant stents, and I'm going to admit that we are trying 10 times, 20 times to do a nice balloon angioplasty before implanting a stent. It's in fact a bailout procedure now. To implant a stent is let's say, the last choice. If only in case of balloon angioplasty it's not possible to be done with a nice result, with nice flow. The stent thrombosis is really an issue for now, for this moment. And maybe in the future, if a better stent, venously dedicated and thromb resistant, can to be done, in this case, maybe the stent will be a primary procedure, but now not. I'm not absolutely not proposing to anybody to implant directly a stent. It's better to do good balloon angioplasty first and on secondary or third procedure to implant a stent only if the balloon doesn't work.
I cannot agree more. So if you think that you can fix the problem once with stents, because in a big group of patients after stenting, there is a restenosis inside the stent, which is far more difficult to fix in comparison with the patient after balloon angioplasty. And unfortunately, there is also risk of conflict with occlusion that cannot be opened at all.
I think it's a very good question, because I think the lay person thinks that. They think, I don't want to have to come again, fix me permanently, put some scaffolding